This is the 12-lead ECG of a patient with sudden onset hypotension and depressed consciousness. Pause this recording now and interpret the ECG on your own before pressing play again to hear me interpret the ECG. The rate is 230 beats per minute with a broad complex. This is therefore broad complex tachycardia and should make you think that the patient has ventricular tachycardia. In addition, one should treat the patient and not the ECG, and a combination of a rhythm at 230 beats per minute with hypotension and depressed consciousness should make one think that they need to cardiovert the patient, irrespective of whether this is a supraventricular or ventricular rhythm. The rest of the interpretation of the ECG therefore becomes somewhat academic. The axis is equivocal with a downwards complex in lead 1 and a downwards complex in lead 2. P waves cannot be easily identified, and therefore it's impossible to comment on their morphology or the PR interval. The QRS complexes are certainly broad, somewhere in the region of 160 milliseconds. Given the breadth of the QRS complexes, it's impossible to comment with meaning upon the presence or absence of pathological Q waves or the ST and T wave morphology. In summary, this is a broad complex tachycardia with an extreme ventricular rate. The widely displaced axis and morphology of the ECG are highly suggestive of ventricular tachycardia, and either way the patient should be electrically cardioverted. Of note, the chest leads do not show concordance, i.e. the chest lead complexes point upwards in leads V1 and 2 and downwards in all the others. This non-concordance is felt to go against ventricular tachycardia in many ECGs, but on balance this probably represents ventricular tachycardia all the same. This sort of differentiation should be left to expert cardiologists and not something to be attempted when a sick patient is in front of you.